My name is Laurie Cathers. I'll only take a minute to introduce myself because we have a very, hopefully, fun training for you today. As Linda told you, I am currently getting ready to defend my dissertation, party, which was, I actually interviewed substance abuse counselors in a community outpatient setting about their experiences treating clients with various medical conditions. Me being in the field of HIV for as long as I have, I know that they have multiple needs. They also have multiple barriers to not only care, but to substance use treatment. And so I wanted to see what the counselors were actually experiencing when they were treating clients, regardless of the medical conditions. And it was really, really fascinating to find out how they adapted their practices and counseling sessions based on the needs of the clients and what the clients were facing. Coming to a theater near you. So who knows, I'm probably going to publish off of it. We'll see. It was just, the counselors are amazing, and I just have an amazing respect for substance use counselors and the work that you all do. I spent, prior to coming to VCU in 1999, I worked in several HIV nonprofits. Been involved in HIV work since 1993. Lost my best friend to AIDS early in the epidemic. So it's something that's very near and dear to me and something I'm very passionate about. From there, I went and got my master's in social work because I wanted to be a case manager, and then I got hooked into research and fell in love with that. I do a lot of community-based research, so I like to be out in the street and in the field. I've worked with LGBT populations, especially transgendered, our African-American communities down in Richmond, as well as Norfolk, and injection drug users of all race, ethnicities, and identities. So that's kind of my background. I have a lot of fun doing this. Thank you all so much for coming. It's very exciting to see that we have a great mix of people, some that are more focused on HIV, some that are more focused on substance use. So I apologize if any of this stuff is going to be review. I can almost guarantee a lot of this is going to be review. But hopefully we'll present it in such a way it'll be fun, it'll be a nice refresher, and get some discussion going. And what I'm hoping is once we cover kind of the hard data part, which is always the kind of hardest part to get through, but we'll make it fun, is we're going to do some activities, and we're going to just work on different ways to talk to our clients about HIV testing, HIV risk reduction, and have some large group discussion, and also kind of frame it in the context of a brief intervention, 5 to 15 minutes. I know, like, for some of my substance use counselors, that may be the only time they have to really work with someone about different risk behaviors. So y'all ready? Get started? All right. We're going to break about 10, 20, and we'll take like a 5-minute break just to stretch our legs and kind of relax, because I put out a lot of energy. So y'all might be feeling, whoa, need to, chill out for a while. So there'll be a little break in here. All right. Oh, and I will warn you that I love ringtones. So if your cell phones are on and it goes off, don't be surprised if you see me kind of busting out of groove. Okay? If you can, please put your phones on vibrate, okay? I promise mine's on vibrate because I don't think any of you want to hear Ozzy Osbourne shout Crazy Train going across the room. So let me tell you, it's so much fun when I forget. I would like to also thank Linda, the Central East ATTC, for sponsoring this today. Okay, so we're going to kind of do a whole overview. I kind of build this like a pyramid. We're going to talk to you about sexually transmitted diseases. We're going to talk about the data in Maryland versus the U.S. We're going to do some HIV. We're going to work a little bit with hepatitis, mainly just kind of giving you the updates. Not all updates, but just some exciting things that I know I'm hearing buzzing around campus, which is pretty exciting to hear some of this stuff. Then I'm going to tell you about this blending product that the ATTCs, the Addiction Technology Transfer Centers, developed. This is out of NIDA, and there was a research study that happened that resulted in this. Okay, so the study came first. So I'm going to tell you about the study, not a whole lot, but a little bit. To kind of give you some background about why this was developed. And I'll take you on a little tour of that, and then we're going to do some skills building fun activities, break out the crayons. Seriously, we're going to break out the crayons. Okay. So although we have many sexually transmitted infections that we have to deal with in this lifetime, I'm going to focus on the main 3 reportable ones: syphilis, gonorrhea, and chlamydia, mainly because those are the ones that we have the best numbers for by region and area. But I don't want us to also forget all the other ones that affect our folks, affect everybody. You know, many people, for example, with herpes go undiagnosed their whole life, never even knowing that they have it, because they've never had an outbreak, or they've mistaken an outbreak for something else. So, and the reason why would I start off with STIs if I'm going to focus on HIV later? Yeah, because if they're putting themselves at risk for one, they're putting themselves at risk for the other. And I work with a lot of rural areas who, you know, their HIV prevalence is really low. And so when I go in and I talk to them about their STI prevalence, I say, you know, just because your HIV is low, they're still doing things that are putting themselves at risk. And it's only going to take coming across that 1 or 2 people that are HIV infected that they're going to really, you know, they may put themselves at higher risk. So to try and get people in thinking in terms of whole sexual health. Okay. So chlamydia. This is bacterial. It infects both men and women. It's a silent infection sometimes. You don't have any symptoms, maybe for days or weeks or months. Symptoms, when they do have them, include discharge, burning, difficulty urinating because it hurts. Chlamydia can be transmitted by anal sex, oral sex, vaginal sex. And right now, the current recommendation that is floating around is to test sexually active women 25 and younger and older women with risk factors, men who have sex with men, and HIV-infected patients. How high do you think chlamydia is in the state of Maryland? Okay.
We screen every pregnant woman at the initial prenatal visit. And we have not just at the Center for Pregnancy, but in particular clinics, we have a very high chlamydia rate. And a lot of recurrence. We're being treated, partners not treated, or partners treated, and having sex with someone else who's not. It just goes around.
Yeah. I work with one of our city health departments, and I'm on the STI coalition, and we meet like every month or so. And that's the main thing is they get folks treated for chlamydia, they get them identified, but they either don't want to tell their partners, or somehow the reinfection happens and they just keep cycling through.
A lot of our population in the regular clinics is self-pay, Hispanic, undocumented patients. So they can get charity care for pregnancy, but the partners are not insured. And they're really scared to go to the health department. They think that everybody is, you know, Homeland Security, so they don't want to go and get registered anywhere. So they won't get deported. So they end up not being treated for months and years.
Wow. Yeah, and untreated chlamydia can lead to some problems, right? Can lead to reproductive problems later on in life. Yes?
So the last thing you have is reinfection.
Yeah. Because when, you know, like for example, women will come in, get treated for chlamydia, they either may not want to tell their partner or their partner may not want to go in for treatment, so their partner's still infected. The woman doesn't utilize condoms or anything to help reduce the risk, so she ends up getting reinfected. So we kind of have that cycle going on.
Will that make them resistant to antibiotics after some time?
Not with this one, no.
There's no resistant chlamydia. And the treatment is one-time antibiotic treatment.
Yeah.
One dose, one time, that's it. It's very simple.
Yeah.
So is that by injection or?
No, it's a pill, it's 4 pills that they take at once. It's azithromycin, health department dispenses for free.
So, country that gives the partner to give to the other one or what?
So in the state of Maryland, and I'm not sure how it is in other states, but we are treating, so I'm talking about chlamydia and pregnancy. We're treating the pregnant woman, we can't really prescribe anything for the woman.
Yeah, but the health department is a quick test with.
It's quick, and actually, if their female partner is infected, and the partner goes to the health department and says, you know, my wife, girlfriend, whatever is infected with chlamydia, they won't even test it. They'll just give the medication.
Yeah.
Well, can you guys suggest this to them because it's like
We do.
It doesn't
But
make
when
sense,
someone is
because
here-
if they keep getting reinfected, it's
Yeah.
because the money, when you can treat both at the same time and.
Yeah.
When someone is here illegally, for them, every encounter with the
Well,
authorities,
system.
doesn't matter which authorities,
Yeah.
is a dangerous encounter for them. I mean, some of them don't even come to get prenatal care because they think we're gonna report
So I
them.
need suggest this to the health department
Mhm.
to allow you guys to, allow them to take.
Oh, it's like
control.
state regulations and
Yeah.
stuff, it's not,
Yeah, it's a medical.
yeah, it's a medical regulation.
Yes.
It's costing us money.
You said, not treated can lead to reproductive problems. Does that affect both male and female?
Yeah, I'm more familiar with the female part of it, but I believe it for the males as well. It can cause some issues later on. So, because I mean, that's just bacteria sitting in there, making their life miserable. So, yeah, it's not fun. It's not. So, all right. So, out of the 50 states, where do you think Maryland ranks in chlamydia? Number 3? Top 10? Top 2? Okay, let's see. Let's see. Drum roll. According to 2011, you ranked 16th. Yeah. Mhm. So, I know. Wait until we get to gonorrhea, though. I love to hear you all laugh. This is good. Yeah, you usually see them together. So what I'm going to, just to let you know, you all have all this on your slides. I have cited, put your citations. These are all active web links. I don't know if Linda can, but she can probably send this to you electronically so you can use the hyperlinks to make sure that at any point in time you can go and see what your state's data is. So everything is referenced through here. Yes?
I want to go back to that.
Uh-huh.
Previous slide, let's say MSM. So if you have the MSM, because normally people think of chlamydia as something that women only get, and then their partners might get it. But if you have 2 men,
Yeah.
and let's say one of them was bisexual, but
Uh-huh.
mainly MSM,
Uh-huh.
they can be giving each other chlamydia
Mhm.
as well. So
Yes.
it can be restricted to
Yes.
men. Yeah.
Yes. Men can get it, give it to each other. Yep. Yep. Because again, transmission can happen anally, orally, or through vaginal sex. Once it, because it's in the urethra and all through that. I'm not a medical doctor, so you'll notice my biology terms are pretty crude. So, in that pipeline, but it's, men can give it to men. And we are seeing quite a bit of chlamydia among MSM.
Where's the state that ranked number 1?
The number 1 state? Oh, I would have to look it up. I was just looking
Just
for
curious.
Baltimore. Yeah. But if you go, if you go down to the second one, the CDC surveillance, it has the state rankings for each one. So it'll be in there. So since you have your data on the slide, I'm not going to spend a lot of time reading you a bunch of numbers. Is that cool? Okay. But what I want to point out is I put kind of the U.S. as a whole versus the Maryland rate, because just to kind of get an idea of where you are. Because again, I believe in whole person health. So when we talk about HIV, we also have to talk about these other things. Because a lot of times our HIV folks are infected with some of these other things that we have to treat. So, to kind of get a broader picture. Yes?
I'm just noticing, blacks are 7 times more likely than whites to get it. And I wanted to ask the lady up front, I don't know her name is Kate. Do you find that you have more African American females?
So I don't have a lot of African American patients. At the Center of Addiction and Pregnancy, most of my patients are white. And at my regular clinic site that I do, most of my patients are Hispanic. So I
In
don't know.
Richmond City, most of our patients are African American. So it's going to depend on where you are in your geographic region. But yeah, what the data is showing is that African Americans there seems to be higher transmission. So, and I think that's more based on our geographic regions and things like that. I can look into that more for you. Okay. And then, kind of interesting, 1 in 15 sexually active females, 14 to 19, have chlamydia. So our youngins are very active lately. Okay. The other thing to note in Maryland, chlamydia among women is 3.4 times greater than among men. So it's 666 cases per 100,000 people versus 195 cases per 100,000 people. So right now you rank 16th. Okay, gonorrhea. This is another bacterial. Again, related to sexual behavior, can lead to pelvic inflammatory disease in women. This is one that you're starting to hear is developing a resistance to antibiotics that they're using. So, and again, we have the same reinfection kind of issue we have with chlamydia. Yes.
What do you mean by sexual behavior?
Anal, oral, vaginal.
Oh,
Yeah. Any type of sexual activity. Okay. So gonorrhea is one of those things you're not just talking about down here, you're talking like right in here. Okay. So, and unfortunately right now it's developing a resistance to antibiotics. We haven't had any antibiotic resistant cases yet in Virginia, but it's something that I know as a nation we're starting to watch. Okay. All right. So where do you think you are for gonorrhea? Third? Who read it? Somebody read it off the slide. So 16th. Okay. So we started seeing, for a couple of years, we started seeing declines in gonorrhea. Now we're starting to see them go up again. So it's one of those things that kind of cycles through.
If this isn't resistant to antibiotics, what's the next best
They use another form of antibiotic,
strong?
different kind. Yeah, I'm not too versed in Americans, but I do know that there's.
One time.
Yeah, it's a one-time shot. So just something to be aware of, you know, because when we talk about HIV, we know that HIV, certain genotypes are getting resistant, correct? So we're starting to face the same challenges here. We just don't know how bad that resistance is going to hit us. All right, syphilis. How many of you have to deal with syphilis in here? Anybody? You do? Yeah? Okay. All right, syphilis is an ulcerative disease. The primary stage, you start off usually with a sore, will heal over time, but syphilis stays in your body even though it heals. And you run into your secondary stage. This is where you start seeing some people get skin rashes. We have people come into the health department going, I have this rash that just won't go away. Find out they're testing positive for syphilis. Then you get into the latent stages. Latent is the hidden stage, no symptoms, but can still be carrying syphilis for years and years and years. And then the late stage, about 15% of those untreated will go into this. And we were talking 10, 30 years after infection. Okay. Syphilis can cause a lot of damage to your body if it's left untreated, including death. So very, very important to get our folks identified. All right. Let me take a quick peek. Okay, where do you think you rank in the U.S. for syphilis? 3 or 4? Do I hear 5, 6, 10? Anybody? 5? You read the slide too. Yeah. See, I knew I should have blocked those out. Y'all are trying to keep me on my toes. Yeah, you rank number 2 in the U.S. for syphilis. Okay. Yep. So now the cases, it may not seem like a whole lot. In 2011, you had 452 reported cases. That's 7.8 cases per 100,000 population. But it still tells you it's still floating around.
I just wonder, what's the difference between on the right-hand column, the top part and then the bottom part?
Maryland, the top part is showing 2008 through 2011, and then 2011 is only that year's data.
So the top is like a summary.
Yeah, kind of a summary.
Okay.
So you can see that over time, in 2007, you went from 345 cases to 378, and now you're up to 452. So your health department is really busy right now. Because I know anytime we have a round of syphilis cases come through Richmond City, it's very, very busy around there because you're working to identify everybody's partners, you know, trying to get out there, get people in and get treated. So, yes.
You say the health department, but I don't see a lot of notices or health notifications about syphilis being so prevalent.
Mm-hmm. You know, that's going to be up to your health department, and I'm not saying it's right or wrong, however they're doing it. I know in our health department, I can only speak from my experience, is we work because you may have 5 or 6 or 7 cases. Not all these cases is going to be in one health department. Now, I would assume Baltimore is probably going to be higher than a lot of your health departments, okay? So they're going to be working to identify, the case that comes in and then notifying all their partners. I know that when, certain levels of infection are reached, then I think they start a little bit more with the media campaigns, things like that. But it's really getting those individuals in because, again, you're pretty 7.8 per 100,000. So it surprises us when we start seeing syphilis cases popping up again.
Yeah, for us to be ranked number 2, I mean, I see stuff about HIV and AIDS, and as far as I thought, syphilis was basically remote, but it's more prevalent than the other 2.
Yeah.
For me, I really wasn't aware that it was ranked that high.
Yeah. Well, also remember, when we rank the states, this is based on reported cases. So it's not like you have 100,000 cases compared to everybody else. You have 452 cases for the year, okay? So you're probably, we'll get to your HIV data in a minute, you may have more HIV cases, but rank lower in the states. Where here, based on what we've been able to do with syphilis so far, in the number of cases reported, Maryland is still around number 2. But yeah, it is. It really kind of blows your mind because we thought we had taken care of syphilis, right? Well, it still pops up, and you'll get, kind of a spread go through for a year or 2 until you get all the cases identified. Yeah.
Is this data only collected through the health departments, and the different state health departments, or is this private hospitals, doctors' offices?
There are certain diseases that have to be reported, so by whoever's doing the testing. So it's health department, it's medical doctors, and it goes to the CDC. So you're looking at chlamydia, gonorrhea, syphilis, and HIV are the primary ones being reported. Hepatitis, I think, is along those 2. I didn't bring, Maryland actually has a thing that lists every disease and who's supposed to report it where, at what time. So if y'all are interested, let me know and I can send that through Linda and we can send it out through the registration. I'm sorry I didn't bring it with me because I was curious to see how Maryland did theirs compared to Virginia. Or here and then here. Or here and there. Either way.
I just want to know how is it transmitted?
Syphilis through sexual contact.
Just,
Okay.
okay.
Sex
Right,
and mother to baby.
Mother to baby, yeah.
Pregnancy.
I was just wondering, what's involved with the testing for chlamydia and gonorrhea? Because I know the needle exchange, they'll do testing for HIV and syphilis through blood draw. But they don't test for anything else. I was just wondering, is it more complicated or more
You can
costly?
just send urine for chlamydia and gonorrhea. I mean, for women, and if you can
Oh.
do vaginal swab. For men, you can do like a urethral swab.
Okay,
But the easiest way is just to have them pee, and versus the urine culture, you tell them not to clean, just pee dirty because you want it.
That explains why they don't test on the needle exchange.
So
Yeah.
probably syphilis is way more diagnosed than chlamydia and gonorrhea.
Yeah, I think it's
being
been
tested.
Yeah. Yeah. We do have some outreach organizations that have like drop-in clinics that are doing the chlamydia and testings. They've been trained to do those swabs. So
Will those 2 diseases only burn when you pee?
Not always.
for some.
Not always. You
Not
can
always,
have chlamydia
for some.
gonorrhea for months without any symptoms.
Yeah. See, some of these will stay dormant. People are going to have different reactions. I mean, I've seen people come in just miserable a couple of days after infection. I mean, dripping. I mean, just nasty. Okay. So, and I feel my heart breaks for them because I know how uncomfortable they are. And then other folks will go asymptomatic for a while. So that's why it's important when we talk to our clients, if they say they're engaging in unprotected sex, that we not only educate them about HIV, hepatitis, but we also, inform them, hey, do you really want one of these? They're not comfortable. They're not pleasant. And you also have to notify your partners because you got it from somewhere. And for some people, that can be really hard, to do. Especially like for some women, they may be in a domestic violence situation, or some of our MSM who may be in situations like that. It can be difficult. So, yeah, so it's important that, you know, if you're sexually active, you should be tested, you know. And the great thing is we do have our health departments, and they're really good about this. Okay. All right. So I'm going to cover a little bit about hepatitis. The reason why I'm doing just a little bit on hepatitis is because I met our new hepatitis state director about a month or two ago and got really excited about the new thing that's happening with hepatitis. Okay. So we have several types of hepatitis. The ones that we more commonly know is hepatitis A. This is usually through food or water contamination. This is the one that gives me the gross factor because it's fecal-oral contamination. It means that, you know, somehow some icky got on whatever we're eating or drinking. So that one just has a real gross out factor for me. It is limited. It's not going to result in the chronic infections that we see in hepatitis B and C. Okay, and there's a vaccine for it. How many of you had your hepatitis vaccinations? Okay. Oh man, don't they hurt? They did when I had them. 3 shots. Is it still 3 shots in the arm? Oh, I hated those things. There is a vaccination for A and B. Okay, so if you haven't had your hepatitis vaccinations, get your hepatitis vaccinations. Okay, hepatitis B can be acute and chronic. It can be lifelong. It can lead to liver problems. Usually get this through skin puncture or mucosal contact with infectious blood or bodily fluids. We see this among injection drug users, sex, childbirth, prolonged non-sexual interpersonal contact. I don't know what the rate is of non-sexual interpersonal contact is. I couldn't find anything. And then C. I work a lot with injection drug users. This is the one that's on their mind. I would go do HIV prevention, and they wanted to talk about hepatitis C. That's what scares them, okay? It's acute. It can be acute. Not everyone's going to have an acute stage, but it's silent. It can be chronic. It can lead to cirrhosis, liver failure, liver cancer, and death. This is contact with blood of an infected person, so again, our IDUs are really high at risk. Needle stick, blood products prior to 1992. Okay, so if people had blood transfusion or any type of blood products prior to that, they should get tested. And we were just talking back there about how they're recommending baby boomers should have hepatitis C test because of the time frame in which they've grown up and everything. There is no vaccine for this. Now the great thing is the hepatitis C treatment is getting better. I remember back when some of our HIV folks would have hepatitis C infection and they would go through that interferon. Man, I was rough on them, really rough. But from what I hear, it's getting better. I'm not familiar with it, I'm not a medical doctor, but I do hear from people that are going through the treatment that it is better than it was, 8 years ago? There's also a hepatitis D and E. We don't really hear about these too much. Hepatitis D is usually if you're already infected with hepatitis B. And hepatitis E is self-limited. Again, it has that ick factor. It's the fecal-oral route. And it's very rare in the U.S. Now here's the exciting thing about hepatitis. Oh, not yet. I'm ahead of myself. It's all that coffee I've been drinking. Usually people with hepatitis B and C are unaware that they're infected. They can go 10, 20 years before even finding out they're infected. That's what's so devastating about it, is because by the time they start showing symptoms or something and go to the doctor, they're already, so far advanced, and it's hard for our folks. It becomes chronic, it remains silent for decades, which increases their risk for disease and cancer. Now, this was interesting, and I was real curious about this. With hepatitis B, if you are, say, in your 50s when you get infected, the chronic infection possibility decreases the older you are when you get infected. So for those that are younger, who get infected younger, they're going to more likely be chronic.
Excuse me.
Yes.
So how long did you say a client, the period of time for her to be tested or her to be tested for hepatitis?
I would say get tested whenever they can.
Whenever they can? No, not, I'm saying they don't know, so.
They don't know?
Every 6 months, every year, how.
It's going to depend on their risk behaviors. I would say get a baseline test, especially if you're in the baby boomer population. get a baseline test. If you've never been tested before and you're worried about it, get a hepatitis test. Okay? Can't hurt to be tested and have a baseline. Then I would, I think they're working on how we're going to do this, because I'm going to tell you the exciting part here in a minute, as far as recommendations for testing. Because like for us, we know our recommendations for HIV testing based on risk behavior, every 6 months, every year, I don't know if they've set that up with hepatitis C yet. They might have, and I've just missed it, but I can check on them. Yes.
After exposure, how long does it take for you to be identified as someone with hepatitis?
I'm not sure what the latency period is for C, 3 to 6. But the thing is a person may not show any symptoms for years. So
Based on the risk behavior, you suggest that every 3 to 6 months?
I wouldn't say like every 3 to 6 months get tested, but based on their risk behaviors, I would say yes, at least get tested regularly. Especially if they're an active IDU that's sharing needles. I'd be really concerned about them. So here's the exciting thing because, all right, let me check. Okay, I still got another slide to go before I get to the exciting part. Bummer. Okay, because I think that's going to help with a lot of questions. So this kind of gives you an idea. Where you see our rate, right here you can see for hepatitis C, we're starting to increase in the number of cases. Part of it is because of testing, okay? So right now we can only estimate, all right? The rest of this here is, you're seeing 0.3 cases per 100,000 in the U.S. That seems like really low, doesn't it? Okay, so then I go here, and we're looking at 3.2 million estimated in the U.S. Okay? So with a worldwide prevalence of 2 to 3%. Now, this is CDC. Again, these are estimates, okay? Because we don't know. A lot of people are sitting with infection that don't know that they have it. Now now I'm at the exciting part. Yes.
Can we go back
Yes.
one more time? When you said 75, 85% you infected with chronic infection, what does that mean? What is that chronic?
The chronic is whenever you're starting to get into liver disease and you're starting to have some liver issues and illnesses, cancer, that type of thing. If you're starting to show symptoms, it's going to be a chronic liver issue. Now the exciting part. Look at that. What does that look like? Okay, other than a pregnancy test, what else does it look like? Like the HIV Aura test. In 2010, the FDA approved the new rapid hepatitis C test. Yes. Isn't this exciting? So all those that are having questions about testing, this is going to be really helpful for us.
That was going to be my question is, so that this sort of testing, blood, is that just as accurate as a liver biopsy?
I think right now they're saying they have like a 98% accuracy rate with this. All right, this is a first generation test. For those of us that have been in HIV for a long time, remember the first HIV rapids that came out, the first generations? They asked us only to test those at high risk, don't do this population-wide kind of thing. They're still, working on it. But as the years went on, we got to a point where it's like, okay, you can do 2 rapids and you pretty much know, for sure. So we still have some time before we get there with hepatitis. So I was talking to our state hepatitis director, and she's like, yeah, we're, getting ready to roll out rapid hep testing. And I went, what? When did this happen? This is awesome, Because now, instead of, when we're out in the streets and folks are worried about hepatitis C, we have to motivate them to go to the hospital or health department to get tested. We can test you in 20 minutes and we can stay right with you. I mean, that just helps so much, I haven't been trained in it yet. I know that some of our substance use centers are being trained in it right now. And the substance use centers that are being trained are the ones like the methadone clinics with high IDU populations, okay? And an outreach agency that works a lot with IDUs. So they're the ones in Virginia that are being tested. I don't know what Maryland's plan is to roll this out. Every state has a hepatitis director, okay? It's kind of following right now what seems to me, just my observation, I could be wrong, again, just my observation. Don't you love all my disclaimers? It almost seems to be following the same trend as when we saw HIV rapid rollout. CDC's putting some money out for states to apply for, to kind of see how it goes. Right now, I know in Virginia, they're asking for us to test our highest risk group, which is our IDUs. I got a lot of questions. So right here and then back there. Yes.
Oh, and Ken just asked about that being more accurate than a biopsy. I think that's used just to see whether or not you have
Antibodies.
Hep C. The biopsy is used when you're known to already have been infected with Hep C, and the biopsy shows what stages or condition your liver actually is in.
Yeah.
And the reason that takes so long before people, because the liver is non-complaining. I mean, it takes a lot of, can go through a lot of abuse before any signs or symptoms start to show up and develop.
Exactly. And this is why this test for antibodies is just like the HIV. So there has to be a confirmatory test, but at least now we can get people screened that may not otherwise go into some place to get tested. So this is, to me, this is like just as exciting as the day that the HIV rapids came out. Yeah, oh, hold on, let me get these guys back there and then right here.
First generation, any idea how much it costs?
That's my question. No, I don't. But I can look it up for you. I need to have Linda make me a list of questions so I can look these up for you. I'm not sure how much they're running yet. So, again, it's going to be your hepatitis director. Your hepatitis director is probably going to hate me now. But she doesn't know me. It's okay. I can take the heat. If this is something that you all are getting excited about, then I think, we'll start seeing hopefully some funds that either agencies on the local level can start going after or something. But I want you to know that this is out here now. So, and it's hope for our injection drug users especially to get tested and get into treatment early. He had a question, then I see that hand, then that hand, okay? Okay, did you have?
No, I was going to ask the same question.
So over here in the room.
Same question.
Okay.
I actually attended hepatitis C rapid antibody test training.
Oh.
I STAR about, I want to say 4 to 6 months ago. And the test is done with blood, so it's not a swab.
It's not a swab,
like the HIV tests are now. And they said they cost around $20 to $28 per test. And that it's a private company that's putting them out right now, so you have to pay for them through their company, they give you a box or whatever. They're a little pricey, and I'm just hoping that it'll come down and DHMH or whomever can get money to get them so they can get them out.
Yeah. Yeah, that's awesome that you've already gone through the training. Yeah, these are finger stick only tests that I know of. Yes.
When you said that treatment is less painful or less of a burden or whatever than it used to be, I know that previously I'd hear that even providers thought that they were concerned about testing because then here this person has this severe illness and there's like no treatment available unless you're rich or whatever. So what do you mean by it's less burdensome? Is the cost less?
No,
Is the medicine easier on you?
What I'm hearing from the patients that have gone through tests or through treatment is physically it seems to be easier on them. They don't feel like they're getting as sick. Now that's anecdotal. I don't know if that's what everyone experiences because I am not an expert in hepatitis treatment. But from what I'm hearing from some of the patients is that compared to years ago when I would have HIV clients just get so sick from it that some would even drop out of the interferon treatment because they just couldn't handle it. It seems like some of the people that I know anecdotally seem to be handling the treatment better. But you bring up an excellent point. And I think we also had this discussion too many, many years ago when the rapids came out for HIV. Once we start identifying people, what is that going to do to our healthcare system? All right? And I hope healthcare reform is ready for it.
But also there's a lot of it is research in terms of hepatitis C. Even with the treatment, if you're chronic for life, it's not going to go away. You may become undetectable on your viral load, but we know that, I can't remember the percentage, but some people are undetectable to begin with. They'll be hepatitis C positive, but you can never detect the virus in their cells because that's just the way your body is handling the hepatitis C. And we see that a lot, especially in pregnant women.
Yeah.
That a lot of them are undetectable throughout the pregnancy, and then after they deliver, the viral load finally goes up.
Yeah.
But I mean, there's nothing that you can offer them. They're still infecting to other people, even if they're undetectable. And it's just, I mean, they know they have it, they know they need to be careful with other people, but you can't really treat them.
Yeah.
Maybe ease up symptoms when they come, but
Yeah.
nothing more.
And then it's, kind of like the cure sometimes is worse than the disease itself. So, I mean, there has to be a lot of discussion with our liver doctors and with the patients and with the policyholders, because we start identifying a lot more folks, we need to be able to send them somewhere, okay? And there ain't no Ryan White funding for hepatitis, So, unless there's still hepatitis. I remember when I was part of Ryan White, we could fund part of a hepatitis liver doctor. That was a long, long time ago, though. I don't know if you still can.
There's some big research at the University of
Yeah.
Maryland that they're doing about hepatitis C.
Yeah. And yeah, you can get to the universities. There's research studies going on all the time for hepatitis C treatments. VCU had some going on. Up here probably has some going on. But yeah, good question. This is exciting. We're going to be able to tell people about their health, but are we going to be able to handle the capacity depending on what the prevalence rate is when we start testing our folks? So, huge question. Yes.
I have some experience with people with long-term sobriety, finding out at 20 years of sobriety or whatever that they have hepatitis C. Many of them are either resistant to the interferon treatments, or they get so ill that they're afraid they're going to relapse. And they'll stop the treatment. And I just had a friend die from complications of hepatitis C.
I'm very sorry.
Cancer, and then, she was following that path you were describing. So, and she was yellow, from the jaundice, and, she had about 4 years of sobriety, so, it impacts the community in a real negative way.
It does. It really does. And the treatments, like I said, they're hard on the body. I've seen, my friends go through it, clients and stuff go through it, and it's hard. You're hopeful that it gets easier, but then if they have other conditions on top of it, so our folks have a lot of health needs, do they not? They do. So, they keep compounding. Her and then you.
I went to a training about 2 months ago, specifically on HIV and hepatitis. And one of the new medications is ribavirin that is used with other medications, kind of like a cocktail type thing, that the side effects are not as severe as the interferon. So there are, Johns Hopkins has a couple of studies going on of that individuals who are Hep C that can participate. And they're still saying that it's a study, but most of them do well with the medication treatment and become one of those individuals who is undetectable. I know about 5 individuals that have had that treatment done through Johns Hopkins that are now cannot be detected. Hepatitis virus cannot be detected.
And that's awesome, because with the new medication regimens and stuff coming out, hopefully more and more of that information gets disseminated down to us at the communities. Because I think too, as word has gotten around the communities, people are afraid sometimes of being so ill from the treatment. So it's better off just not knowing. But if we can start getting more information disseminated down to the community about these are the treatments, you have alternatives, you have options. We don't want people to think they just have one option anymore. They have options, and one of them may work better for them than some of the others. So thank you. This is great. I love the information sharing that's occurring in the room, because I'm not from Maryland. I'm not going to pretend to know your system. So the more y'all can share about what y'all know about this different stuff, the better.
I've had 2 of my clients tell me that they took the pill for 30 days.
I'm not familiar with that one, but I can look it up. I know they're getting really advanced with how they're treating hepatitis. It seems like new stuff's coming all the time. So I can take a look at that.
Well, to your point about improvement, years ago, it was just an interferon, and you have to take that with a needle. And that was done on a daily basis.
Yeah.
Now it's moved that you use the needle only once a week in conjunction with the liver biopsy. Most African Americans do not fare as well as people of other ethnicity, but you still have those side effects from it.
Yeah.
And it can vary depending on each individual, what other conditions they may have and things of that nature. But the needle itself has gone from daily to once a week.
Yeah.
Which for a lot of people is a great relief than others. So.
Yeah. Yeah. Especially for those of us who don't like needles.
I had a friend, and he took the interferon and was miserable, hair fell out.
Oh.
He was about my size, and he started taking milk thistle, and now his hair grew back. He's heavyweight.
Yeah.
And he swears by it. He said he'll never go back to any meds, and he just takes milk thistle.
It's a liver, it's a herb. Yeah. Milk thistle. Milk thistle is something that you can take to detox your liver. So I know exactly what he's talking about. It's an alternative therapy, so I ain't going to say one way or another, I'm not a medical doctor, but yes, milk thistle is widely available and people swear by it as a liver detox. So I know my husband keeps, did you find any milk thistle? I want some milk thistle. I need to clean my liver. I'm like, why do you need to clean your liver? He's like, because our liver processes all the poisons and everything. You got to flush it out from time to time. And I'm like, okay, I'll see what I can find. So yeah. All right. So here are your hepatitis cases. As you can see, it looks pretty low. But remember, a lot of people are unaware of their infection. That you can, start to see a few more cases are starting to be picked up.